What's up, Misha?
All right. Hi, everybody. So you asked me, Janet, to give Katalin an introduction, so I'll do it differently when right before she goes, because Katalin and I go back pretty much to my beginning. So that's exciting. Anyway, so you all heard. So I do apologize if you start getting funny things with my connection. I'm here in Wisconsin, about a half an hour north of this place called Hayward. That's going to be the end of the race tomorrow. Well, I hope that will be my end of the race tomorrow if I make it to the end. That is, it's a grueling race. So for details and for Fundraiser, I put the link in there, and you can see my poles. My poles over there, and my skis are at the shop for getting professional waxing. I don't trust myself with any of those things. It's been 30 years since I did any competitive skiing. So, but anyway, I think it's a good thing, and it causes a lot of anxiety, which is what I'm going to try to combat with our practice in the second half of an hour. But let's drop into our usual topic. I am sure that those of you who are insistently checking the news, like all of us nowadays, and again, we don't talk politics on this channel, so that's not what I'm about to show you. But of course, you may have seen in the news the Yale study that was just published on February 19 in preprint in the MedRx IV. It's a pretty high quality, small study, but high quality study linking COVID vaccine to a spike of this mysterious illness of what's called post-vaccination syndrome, which in part reactivates EBV virus and in part just stimulates the immune system. So this is this is actually from the Yale News directly rather than other sources. I prefer to go to the source itself. And then, of course, those of you, we have some of you here who are really all about reading the science yourself. So here's the link to the preprint. Now, it's not a finalized article. I haven't read the whole thing. Obviously, I'll be doing a video when the final result comes out. It's probably not going to be for a week or two, but of course, I'll review this. So what's the significance of all of this? Well, we've already talked on this, in this meeting several times, that there's been some preliminary suggestions that mRNA vaccines not only spike direct immune response to the future infection, but that they tend to upregulate immunity in general. The sort of extent of this is not clear, and there's a lot of not known facts. So studies like this are really important because they're beginning to shed light. So what they did is they took a group of those patients who self-identify as post-vaccine syndrome. And the post-vaccine syndrome is basically nothing different from long COVID syndrome, where people experience a lot of fatigue, a lot of brain fog, sometimes some shortness of breath, sometimes muscle discomfort and weakness. So kind of a typical, although I think in this situation, there's less POTS, of postural orthostatic hypotension. Sometimes we describe that as this kind of autonomic instability of a central nervous system. So there seems to be less of that here. And also quite important to point that in a significant proportion of these patients who had this, there was a pretty high percent who had an EBV virus reactivation. That seems to be the sort of most interesting or completely new information. While upregulation of some of the inflammatory markers like TNF-alpha, for example, has been already shown before, and I've read some studies on this, the fact that there is potential reactivation of the mono-like syndrome, or EBV virus itself, that's a new information. Of course, we also know that that also happens with the COVID itself. So, take it for what it is for now, and I'm sure this is going to spike additional research. And I don't know. I find it kind of funny, the timing of the publication. Again, no politics on this channel, right? So I figured I'll put this out there. We'll track this more, and then that's all I have for today. I decided that now every other week or so I'll be checking in with WHO website, since now we're completely clueless about what's going on in our own country since the data has not been updated. But WHO unfortunately updates their data once a month, so it's not very Yeah, it's not frequent enough. But anyway, the trend seems to be continuously down. Last they said it was getting close to almost under 8% of continuous circulation of the illness around the globe, and some countries have up to 20%. But anyway, there seems to be a continuous drop down. And frankly, I haven't seen any COVID patient. I don't know if Katalin had in the last couple of weeks. We see a ton of flu, see a lot of just cold and a lot of infectious diarrhea, but really not much COVID. So that's all I have. Let's do a couple of minutes of questions and hand it over to Katalin. Then I will do introduction. So you know the drill. If you can't type, raise the hand, unmute and speak. If you can type, type. CCC is still not publishing info about respiratory viruses. I don't think so. I think they're publishing, like there's no continuous updates anymore, right? So that was discontinued. What they're doing right now is they're just kind of leaving the information static. So you can just go and find, like, for example, let's say you want to find the update on RSV vaccine. You just go to the CDC and you look for it. The problem is that the updates have been stalling. You know, in the past, CDC, at least with COVID, they were updating pretty regularly. I don't remember how often, but regularly. Now there hasn't been much of anything. You know, and that actually stopped quite a while ago, even before the new administration took over. I think they've sort of been giving up on the tracking. So no, it's thought to be reactivation. This are the adult patients. It's very unusual to pick up EBV in, you know, when you're past young age. It's possible, but it's uncommon. So these are clearly reactivation cases. You know, there's actually quite a lot of discussion about this. It's not 100% certain that this is a real thing. There's been total lack of consensus, whether it's just an upregulation of immune reaction and there is no actual reactivation, or if there's an actual reactivation, meaning that the virus multiplying again. And they're suggesting this in this study. They're basically saying, we're going to study this more. We think that this is what's happening, but we don't have their numbers are small. They only had 40 some patients in total. And so that's not enough to make any kind of serious conclusions. But of course, you know, because how carefully each patient was followed and what kind of markers they assessed, even if they're all just case studies, they still have significant value, right? Because when you report something quite new that has not been reported before, you have to take this seriously. You can't just say, oh, that's not important. You know, it's also, I also, you know, the study comes out from like one of the most prestigious infectious disease research centers. So this is not some, you know, anti-vax thing. I mean, this is a real deal. They're not trying to say vaccines are bad. They're trying to say, look, we need to acknowledge that there is more going on here. And then, you know, the more we learn, the better we will educate the public about risks and benefits. So I think it's a critically important. All right. Yeah, so right, that I've also read. There's also a pretty aggressive now political pressure because apparently from what I'm reading, the bird flu vaccine has been developed a while ago. And in fact, the company that developed this, I forgot the name of it, they applied for FDA approval like 3 months ago. And it's not clear why instead of vaccinating cattle and chickens and all the birds, we're like killing them. Like that to me is very bizarre. Like, you know, there's something there 100 million chickens that were killed in the last few weeks. And so of course, you know, best present for the Valentine Day was the box of eggs, right? So, I mean, we're all suffering from increased prices and it's not clear to me why they're just not rolling out vaccine. Again, I'm trying to stay out of politics here, but presumably that may be the reason actually. Yeah, so they are saying that, you know, that's the whole point. Like, you know, if the meat is undercooked somehow, apparently there is some risk. Now, I don't, you know, I'm not a virologist. I know maybe Katalin knows more, but they are killing them because of that. They're saying that because there's a theoretical risk that was the sort of the latest suggestion, and that's what every farmer is supposed to follow. But to me, it's bizarre if the vaccine already in the process of approval, and why is it taking so long to get it approved? It's not like this human's going to get vaccinated. It's going to be, animals, and so there should be a lot faster path as long as vaccine seems to be working. I mean, that should be, better than killing them, right? So can't stay out of politics when it's touching him. Yeah, well, you can guess my feelings about Ukraine and Russia now after all of that. That's just like, yeah. I'm still trying not to put any Facebook comments because it's not like I've done it before. Katalin knows what happened to me well in detail. She was privy to the whole story, so I'm not doing this mistake twice. We have this famous Russian expression: "Don't step on the same rake twice to hit you in the head." So
No shit.
we follow that. But yeah. Seem like we can. So the best thing we can do though is to control our own reactions, not to let the craziness of the hurricane to draw us in. So part of the practice we're doing today is called the eye of the hurricane, which we will place ourselves in and try to practice some balanced breathing out of that. All right. Well, we're about the time. I take another question or two, but not, and then we can move on to Katalin's presentation. So, all right. Okay. Well, it's a tremendous pleasure for me to introduce my first mentor and now a good friend and colleague. Am I freezing? I think I'm freezing.
You're freezing. Your voice is okay, but the video's not working too
All right.
well.
Can you guys hear me? I'm gonna
Yes, we
try
can.
turning off the video and see if that gets any better.
Yeah.
We can hear you clearly, Misha.
I can introduce myself too. Take it easy.
I'm back. I hope if this is, I'm afraid this is gonna keep happening though, because they're just, but anyway, we'll do our best. Anyway, what I was saying is Katalin has been my mentor first, then a friend, now our colleague. So it's a tremendous pleasure for me to introduce her. She's been at GW definitely more years than I can count. And she's not only a physician, but she's also a lawyer. So she was a lawyer in past career before the entering medical doctorate program. And also she's still carrying that lawyering with her. She's on ethics committee at the hospital. In fact, anything ethics that ever happens on our alma mater, we always go to Katalin first. So it's not a surprise that I think she tackled I think ethically, one of the most challenging issues, the death with dignity law. And she was highly instrumental in putting the law in workings. In fact, she, I believe, was the first physician who saw a first patient going through a program. And I actually got honors and pleasure to see that patient too. So, Katalin and I have been partnering on numerous patients, whether it's regarding cannabis or just really palliative cases. And her expertise spans not just to the chronic pain and palliative, but also to anything geriatrics, and also to pretty much any complex cases and on older people, or anybody's parents on campus, faculty, they all go to Katalin. So she's been like a mother to our division. And she's no longer division chief for quite a number of years. Dr. Prather is, but previously she was the division chief. So I can keep talking for like 20 minutes, but I'm going to stop and head it over to Katalin to talk to us a little bit about death with dignity law in DC and her experience and her expertise.
Well, it's a pleasure to meet with everybody. You can hear me okay? Audio's working all right. So I started out in primary care, but I finished medical school in '82 and stepped right into the developing AIDS epidemic. And so I don't remember what it is I thought I was going to do, maybe women's health, but I ended up being an AIDS primary care clinician in Philadelphia for quite some time. And You know, at that time, that was hospice as well as other things. I mean, there wasn't a lot we could do except hold people's hands as long on the journey. And that really did stay with me. And that was my introduction to hospice and also to medical aid in dying. Um, and I've been really interested in medical aid in dying for a long time. Timothy Quill brought it to national medical attention. I'll put something up in the chat in the early 90s following the Oregon experience. Um, Kevorkian was even earlier. And it's definitely something that um, has been part of end of life caring as a question. And patients say, why me? Or I'm not going there, or I want to get it done. And that's not new, right? Freud's doctor helped him. We know it's since time immemorial in medicine. The Hippocratic Oath actually explicitly forbids giving too much pain medication to end someone's suffering. But the Hippocratic School of Medicine was only one at the time in ancient Greece, and they also opposed other things like abortion, I think, is the other large issue. I mean, it was very good in many respects about thinking about doing no harm and maximizing benefit and not taking advantage of patients. But this has been a controversy forever in medicine. Um, I I see this as part of my medical bag of tricks in palliative care. It's one of the things I offer to patients. It's certainly not something that I encourage people to do, but I understand that for some people it's the right way. And I support that. I had nothing to do. I'm not a DC resident, and it all happened sort of quickly without much fanfare in the summer of 2017, but I didn't have anything to do with the passage of the DC bill. But as Misha points out, I was the first doctor, I think, to prescribe under the law, and it was a patient actually who Misha referred to me, and her name was Mary Klein Dawson. She was a very vital woman who, um, maybe it's Mary Dawson Klein, but I'll put this was all written up in the Washington Post the November after she died. So I'm not divulging anything confidential. She wanted people to know, and she was a big advocate for the DC law. She had ovarian cancer, which she struggled with for many years, and she knew it was going to get to her. And I'm actually now in the process of helping to form a not-for-profit to support the DC law. DC is a little unusual. There doesn't seem to have been a grassroots movement in support of aid in dying. And unlike some states, like End of Life Vermont was advocating for aid in dying for 10 years before Vermont passed its law. End of Life Washington, similarly in Washington state. But DC has not really had its own advocacy group. I just want to talk about what it's like to do medical aid in dying and then open it to questions. The DC law was passed 2017, 2018. It has a residency requirement. It's very similar to the California law. And the first few states that passed medical aid in dying didn't really think about a religious exemption, but it's a sign of how much our political landscape has changed, that people didn't have conscience objections that were much in the conscious forefront in the 1990s. But by the time the California law was passed, I think it was 2014 or 2015, religious and faith-based medical healthcare institutions were very concerned about medical aid in dying and carved out a religious exemption. And DC copied the California law. So it's medical aid in dying is not something that is supported by some faith-based institutions. Otherwise, it's pretty standard. We have a 2-week waiting period for residents. They have to have an illness that has a very serious prognosis of less than 6 months. People have to be competent. They have to be psychiatrically not their decision to end their life should not be influenced by psychiatric illness or dementia. They have to be able to make a free and voluntary request orally and in writing. And the process takes at least 2.5 or 3 weeks, because after the first request, there's a mandatory waiting period of 2 weeks and then another 48-hour waiting period. And that is pretty standard, although a few states have now changed the waiting period, shortened it for people who are very ill. But there are 11 jurisdictions in the US that support medical aid in dying, almost the entire western part of the US. Oregon, Washington State, California, New Mexico, and Colorado all have medical aid in dying, as does Hawaii. On the East Coast, we have Maine and Vermont and New Jersey and DC. And but if you look at the population, it's about a third of the US population has access to medical aid in dying. And basically, the person has to be able to independently ingest the medication. There's no IV administration. This is not Canada. And so people need to be able to swallow. And if they cannot swallow the medication because of their physical illness, they need to be able to push the syringe. ALS, Lou Gehrig's disease, often impairs swallowing. A lot of the people, maybe a third nationwide, of people who take advantage of medical aid in dying, a quarter to a third, have ALS. I mean, cancer is by far the leading diagnosis. Other neurodegenerative diseases like Parkinson's usually do not have a rapid progression. And so somebody with Parkinson's probably has a survival that exceeds the 6-month recommended survival, and they usually do not qualify. And then some of my patients have had either very advanced heart failure or very advanced lung disease, as those are the other 2 big categories. Sometimes people with advanced kidney disease as well, although I haven't had too many people in that category. And I don't want to argue the merits, like, is it ethical to ever prescribe medication for someone? I think the vast majority of people in the states or the jurisdictions where medical aid in dying has been legalized feel that in some situations it's ethical. That's not to say in every circumstance, but we certainly can talk about that. And it's not for everyone. And people who request medical aid in dying and who access a prescription don't necessarily take the medication. The data from Oregon and California is that a quarter to a third of people who request the medication don't use it. The reasons for that are really interesting. Sometimes people just haven't been able to be taken seriously their pain hasn't been taken seriously, or other aspects of their suffering. And by asking for medical aid in dying, they get real palliative care and they get the kind of support they've been needing. Also, sometimes people get ill and they forget that. I've had patients who've forgotten that they had the medicine. Well, usually those are people who have tumors in their brain. And there's a category of people who fear great pain or great disability and then find that dying is not so difficult and they do not have the kind of pain that they feared. And I try to offer everybody good palliative care so that if they can be comfortable without taking the medication, that's very important. Everybody should have good palliative care. And so I think I'm going to
Can I-
stop right here
Perfect.
for
Oh, yeah,
questions.
perfect. I was gonna say, because I know Chris has to leave and he has a very interesting
Oh, go right
question.
ahead.
There's
You
a
go
question
first.
in here. So it's a question about using VSED as a bridge to medical aid in dying before patients with dementia lose capacity. Chris, I don't know what VSED stands for. I'm sure.
It's voluntary stopping eating and drinking, and it's a great question. And voluntarily stopping eating and drinking is something that, of course, again, is a very ancient technique, but it's not easy to stop eating and drinking. It's used quite a bit in jurisdictions where medical aid in dying is not legal. And hospice has mostly come around to supporting that, but it's really hard for people not to eat or drink. So the only people I've had who've done that were Virginia residents who had ALS and couldn't swallow and were dependent on a feeding tube. But if your loved one asks for a sip of water, I recently had a patient who was done and determined to go. But on day 3, she asked for water and her caregiver couldn't not give her water. So that takes a little longer. It also is sometimes uncomfortable, depending on the individual. But so I would say that VSED is definitely available for people who have a religious prohibition against suicide or are living in a place where aid in dying is not available. By the way, since I used the dreaded word suicide, let me just say the preferred terminology now is we went from PAD, physician-assisted dying, to MAID, medical aid in dying, to AID, which is now the preferred term, aid in dying. Opponents often still call it physician-assisted suicide. The psychiatrists and the suicidologists have come out saying that medical aid in dying is not, in their minds, suicide. It's driven by different considerations entirely. But it does require people to do something active in order to stop living. And so people view that differently.
So, Dr. Roth, may I ask a quick follow-up question?
Sure.
So, if you have dementia, um, you can't take advantage of medical aid in dying, as you explained. But while you have early dementia, and you still have decision-making capacity, my question was this: if you are very worried about having advanced dementia, then what do you think about the idea of when you have moderate dementia, still have a decision-making capacity, going on to VSED so you can come within 6 months of your death so that you then go on to hospice and then take advantage of medical aid in dying?
Well, so it's yes and no. People eating and drinking is a great pleasure, and people don't always know how bad it's going to be next month or 6 months from now. So certainly there are people who undertake to stop eating and drinking, and then they die before their dementia progresses. And hospice and most palliative doctors will support that. I mean, if I have a patient and she says, I'm going to stop eating and drinking, it's it. I see it coming. I can't remember what Act 1 was. I'm in the theater. I know it's Act 2, but I don't remember what happened in Act 1. That would be fine. But it's really hard for people to do that. What they cannot do, I mean, you can play a kind of, game of a legal game and say, well, I'm going to do VSED, therefore, since I'm going to do VSED, doctor, you can prescribe for me because I promise I'm going to do VSED and therefore I'm going to die within 6 months. Can't do that. I can't say that the person has a condition that is going to shorten their life. There's an interesting book by a woman named Amy Bloom, who's mostly a novelist. I think it's called Unloving, but it's Bloom. And she took her husband, who had early Alzheimer's, to Switzerland, where he undertook to end his life. Now, people do that, but it's extremely hard. What you cannot do is write a medical directive saying, when I don't know my children's names, or I think Roosevelt is president, don't feed me anymore. We can't do that. That's not legal. So it's very hard to get around the dementia question, but many people are very vexed by it.
Yeah. Dr. Roth, thank you so much. I'm sorry to have to run, but it's a pleasure to hear you talk, and I look forward
Have
to
a great tennis game. I
Thanks.
hope that you're not playing at Carter Barron because I hear it's freezing in there.
Right. Thanks so much. Take care.
Okay,
Bye-bye.
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 So let's see. What actually happens once you ingest the medicine? I'll go back to Jean's question after. Let's see. The status of the movement for this in Maryland is support compassion and choices. It's supposed to be very close in the legislature. Talk to your state rep because it's very close. They say they're only a vote or two away. Delaware, actually, the legislature in Delaware passed a medical aid in dying bill last spring, and the governor vetoed it on the last possible day. How do you verify that someone doesn't have a psychiatric condition that would prohibit treatment? Look, lots of people have seen therapists, and I don't want to be to discriminate. No one wants to discriminate against someone who has psychiatric illness. Somebody who is bipolar or chronic depression or has even schizophrenia should be able to choose medical aid in dying if they are competent and their psychiatric illness is not getting in the way of their decision making. But the law requires that if there's any question about that, a psychiatrist also has to evaluate the patient. And Randy, these are really, I could talk about this all day. What happens when you ingest the medicine? We used to use barbiturates. Now barbiturates are not available, so we use a cocktail of morphine and Valium and medications that will stop the heart and a little bit of phenobarbital. And what happens is that the person falls asleep. They have to be able to drink 2 to 4 ounces. You have to drink it fairly fast because you don't want to fall asleep halfway through. And it's very powerful stuff. But people drink it down, in my experience, with great determination. And then they talk for a few minutes and they fall asleep and they never wake up again. It can take 15 minutes to die, but it could take 5 hours also. Most of the time it takes 30 to 90 minutes for people to stop breathing. Depends on a whole lot of factors, but people fall asleep and they don't wake up. So to Jean's question about 103 years old, dementia, and she's not eating. So slowly she will die. She's doing it because people with dementia often lose their appetite. Older people lose their appetite. She can live a long time on tea and honey and juice and Ensure, but eventually we need more nutrition than that. So, and then it's a very normal way for people to pass, to eat less and less. The less you eat, the less you have to worry about abdominal cramps, peeing, pooping. People are very comfortable when they stop eating, and we try not to force them. What other question? What is palliative care? Well, palliative care is not giving up on your patient when your patient has a severe illness and walking the walk with them and holding their hand and taking the journey with them. And that may be about talking, it may be about pain management, which I do a lot of, symptom management. Thank you to Misha for teaching me how to use cannabis to help people. But palliative care, you know, those stories about how once the doctor can't do anything anymore, they say goodbye. That's the opposite of palliative care. I mean, I think palliative care is good primary care, is good medicine, but we're very specialized. So my ideal is the patient, is the doctor who keeps coming to the house and making house calls, even when there's not much you can do except say hello and hold their hand and make sure that they're tidy. I mean, palliative care is all those things. And I guess the other thing is that palliative care has been assigned the job, now that we are more of a specialty, of doing end of life goals of care, advanced care planning. So a lot of doctors now say, I don't really need to talk to you about whether you want to be resuscitated. Go talk to palliative care. So we do a lot of that. I don't know if that fully answers your question, but palliative care is what you hope your doctor would do for you at the end.
Well, good. I think sounds like we at
More
the end of,
questions?
yeah, I think we're good, right? Anybody else have? Sounds not good. Well, Katalin, it's always pleasure hanging out with you in all kinds of forms. You can stay or you can go, whatever. We're just gonna do.
No,
We
I'll
have
listen. I can't fall asleep because I have a French class at 3. But I would, like everyone else, I can use a little centering and grounding. So I'm going to hear how the rest of the meeting goes.
all right.
Lovely to meet everyone and to see old friends.
There is a question there, of course. At what point would someone talk to palliative care doctor about end-of-life decision making? So, see, Katalin, they don't ask easy questions.
So actually, this is a really great question. It's my new thing. We used to wait till the last minute, or we used to think, you know, when the patient is at the very end. And we still get consultations when it's late in the game. And the same way that hospice sometimes gets referrals a day or two before a patient dies. Really, you want to get to know people. And the standard of care now is to bring a palliative care in early. Doesn't happen, but like ASCO, the oncologists recommend as a standard that when a patient has either a hematologic malignancy like leukemia diagnosed or stage 3 or stage 4 cancer diagnosis, that palliative care be brought in at the beginning, so that people can have some idea of what they're getting into, what they're signing up for, what the doctor means about, we'll do this chemotherapy and then we'll see how long we get. What is the doctor talking about without palliative care? In ALS, palliative care may also come in, usually not the day the diagnosis is transmitted to the patient, which is a pretty terrible diagnosis to have to give somebody, but soon at the second or third visit, because people have a right to know that they can organize their affairs, and that they have choices along the way, and that if they stop doing treatment, one thing I see that makes me so sad is when people decide that the treatment is too onerous, the likelihood of success is not so great. They're puking their brains out and they feel awful on the chemo, that it doesn't mean their doctors are going to abandon them. There's still a lot of work to be done with your medical provider, and palliative care does that. So I'm a big advocate of seeing people early in the course of their illness. I mean, if somebody has a breast lump and a stage 1 breast cancer, they should think about mortality and who can make decisions for them, but they're not really facing an imminent um, a really imminent decline. So for stage 1 or stage 2, highly treatable or curable cancers, there's no recommendation to bring palliative care in at that point. But, you know, for the person who gets diagnosed with certain illnesses that we know we can't fix, bile duct cancer, pancreatic cancer, glioblastoma, or the person who presents with a small lung cancer but already mets to their liver, they should have a palliative consultation early in the game. And Medicare, I would just say that the Medicare annual wellness visit does recommend that doctors talk with their patients about their preferences at the end of their life, but it's probably skipped more than any of the other prompts.
Well, thank you, Katalin, so much again. Let's begin a little bit of our exercise now. So I'm gonna lead us into a little bit of practice. We have about 10 minutes. So go ahead and just find a comfortable position. If you want to lay down for this, that's fine. If you want to stay seated, that's fine. Close your eyes. I think that's actually quite important. My only concern why I can't close eyes is because my connection is not great, so I don't know what will happen. I may need to pause and come back when it reestablishes. So the dedication of today's practice is we're all in a kind of a hurricane of things around us, not just politically, but in generally. It seems to be a lot of uncertainties on all levels, whether it's a climate or economy or politics or whatnot. And so, you know, we often go through the phases. I'm sure you all will appreciate the fact that, you know, you sometimes may feel really okay and stable, and then in other times there is going to be some internal spike of anxiety. Well, it's quite active for me right now because I am anxious about what's going to happen to me tomorrow. And so I think what I decided we're going to do today, we're going to do two things. So one, we're going to do 4-7-8 breath, which we're going to do in a couple of minutes. But before that, close your eyes, center yourself into the breathing. So start shifting attention to work of breathing, tracing, inhale in and exhale out. It It may help to inhale through the nose and exhale through the mouth. You don't have to pay attention to specific parts of the body, just stay present to the breath. And now I'm actually inviting you to center your thinking about something that makes you anxious. Like I'm doing this on purpose. So one way to imagine this, if nothing comes right to your mind, just imagine yourself standing in the middle of some kind of a weather cataclysm, whether it's a hurricane or just a bad storm or a strong rain or a cold, and you're right in the middle of it. And your job is to find the centering and to not being shaken by the elements so that we stay steady, that we don't lose not just our cool, but that we don't lose our attention to the breath and we don't lose our central nervous system balance. So autonomic nervous system balance. So I'll give us a minute or two. Let's do a couple of minutes. So visualize this impact on your system. So of course, for me, I'm putting myself into tomorrow's race. You can put yourself into something imaginary if you want to, or into something more tangible from the past that already happened to you and you got through this okay. Don't imagine things that are invoking traumas or that you think are too hard for you to deal with. So invoke something that's anxiety provoking, but not overwhelming. So. Pay attention how your breathing changes. It may speed up a little, or it may become a bit irregular. If you're pretty balanced to begin with, you may not notice any difference. You may have a capacity with your breath to balance the state of anxiety right away, which is okay. Just stay present to it. And if you're noticing shifts in the breath, if you're noticing you're struggling through any parts of the breathing, just continue. Just don't get too engaged. Just continue the breathing. Okay, let's do 2 more breaths here. Okay, and now we're going to do the Andrew Wiles 4-7-8 breath. So we've done this before in this channel. So you're going to inhale on count of 4. So inhale 2, hold on count of 7, 2, 3, 4, 5, 6, 7, and exhale on 8, 2, 3, 4, 5, 6, 7, 8, and continuing inhale on 4, hold on 7, exhale on 8. So importance of this breath that's really quickly capable of shifting us from the overstimulated sympathetic tone to balanced or just relaxed parasympathetic tone. So 4-7-8. Let's do this we're going to do this for about 3 to 5 minutes. I encourage you to continue doing this. If you start getting very sleepy, you may want to stop at that point. Otherwise, just continue doing this. As I said, we're going to do about 3 or 4 minutes. Inhale 4, hold 7, and exhale on 8. I put counts into the chat if needed. And keep an attention on how you feel. If you notice that you're suddenly getting tired, sleepy, this is all okay. As I said, you can stop the practice at any point if the sensations become a bit too overwhelming. Otherwise, just continue with this count. And it's easier to breathe in and out of the nose here. If you're having a hard time keeping this breath, I recommend that you drop the 7. So you inhale on 4 and you exhale on 8. That's also okay. Even if you're not struggling, you can still try inhale on 4 and exhale on 8. Some people actually prefer that. It sometimes feels a bit more natural without a pause, without a hold. The importance here is that the exhale is twice the length of inhale. That's the important point of shifting into the parasympathetic tone, so into the rest and digest. Another really effective use of this practice, if you're in a very stressful situation and you need to eat, I highly recommend you always do this breath before you eat in that setting, because we really, for us to digest food well, we have to be in a pretty relaxed state. If you're just being hit with some really stressful news, or you have to be in some kind of stressful environment, eating is you're not gonna digest as well, because your digestive system requires to have a balance. Otherwise, you may get bloated. You're just not going to digest food much. You may have a backup. You may have constipation. You may have problems with the eating as a result. Let's do 2 more breaths. Okay, slowly come back. You're probably wondering, how long should I do this practice if I'm going to take this on to do daily? I generally recommend to do it for no longer than 5 minutes. So, 5 minutes twice a day. For sure, best to do it in PM when body naturally winds down to sleep. So this practice can be used to help sleep and to help digestion just before eating or even during. So, hopefully this was helpful. I sense a lot of kind of heaviness and silence. I think that's expected. This was a very difficult presentation to take. I do think that we will continue with this topic on a regular basis because I think it's a very important topic. Chris is going to come back. He's going to do establishing a couple of things. So he's going to do like an ethical will and also like the actual medical will before you get sick. So he's going to help us to deal with that as well. I'm not sure exactly when. But other than that, thanks, Janet. I was just going to say, I was looking for the date. What do we have next week?
We have you and you, unless I can find somebody to do the mind body practice.
Well, all right. Well, I'll give you little highlights from the race and the lessons learned in addition to whatever happens.
Okay.
So Jennifer, yeah. So I love when there is a really strong state of anxiety. I like 478 the most because it can really drag you out of that state within a few minutes. There are no other practices, in my opinion, that work faster than this one. Of course, you can practice anything you want, and some people really prefer methods that are a bit more movement-based. You know, I personally love to just move, and then that helps my anxiety. But when you have something that suddenly dominates and you can't go and exercise in 10 minutes from today, from the moment this happened, I think the 478 is one of the most universal tools. That's why I wanted to do it in this particular fashion. So I hope I didn't cause anybody excessive anxiety when you're imagining something. But I do recommend, if you don't have anything continuously pressing on you, that you actually practice this way. So you will pick something that happened recently that was relatively stressful, and then you will practice through it the same way we just did. So, all right. Well, I think we are at the time. Thanks, everybody. It was a good showing today. I think we had almost 30 people. Jan, let's go ahead and stop the recording, if not already. And I'm going to hang out here